Well, Dr. Lindy, thank you so much for joining me today.
Thank you for having me, Arlena.
Yeah, I am really excited to have this conversation because I'll just be transparent in the sense that I have some apprehension around things like moderation for sure. Like that makes me really nervous. Um, and I am very much in support of harm reduction. But I realized, maybe I need some expert advice and perspective on what it really is. What are these things? Where are they useful? And maybe we can talk pros and cons of each.
Mm.
And of course, we're going to talk about RIA health. You're sharing with me that the Spanish root was estuary, but also RIA stands for reduction in alcohol.
That's right.
Yeah. So that sounds like a path of
The company got named before I got there. I've been with them for almost 3 years, and it got named a year or two before that. So,
oh, nice, nice. Well, let's start off with some basic terms. How would you define harm reduction?
so harm reduction, I think, is much more easily understood when you look at drugs other than alcohol. And I think probably the best example would be either heroin or stimulants. And in fact, the idea of getting people to stop injecting these drugs, I mean, they're commonly injected. And harm reduction there is to get people to not use a needle and switch to smoking or snorting, which causes less overall harm. So I think
Oh,
it's
wow.
pretty non-controversial with those substances. I think with alcohol, it's not as clear, but the way that I think of harm reduction for alcohol is that at least a lot of patients that I see are very heavy drinkers. So these are people drinking 8 drinks a day or more is not uncommon, patients that come to us. And it's very, very clear from research that if you can go from 8 drinks a day to 1 or 2 drinks a day, which is obviously not abstinence, that essentially your health risk reduces dramatically in terms of impact on the liver, heart, bone marrow, et cetera. And so, one might say, well, 1 or 2 drinks a day is too much and isn't healthy in and of itself, which has kind of been borne out by recent studies. But if you compare it to where someone's coming from 8 drinks a day, it's fantastic. And in fact, avoiding heavy drinking is a very positive long-term outcome for patients that I see. And in fact, a really typical patient that I see may be drinking 6 or 8 drinks a day when they arrive. And 6 months later, 9 months later, they're drinking twice a month, 1 or 2 drinks. And so again, that's technically not abstinence, but harm reduction. So I think the devil can be in the details. And I think the reality is there is a subgroup of patients that clearly need to stop completely. And in fact, people will come in and say, I want to be a controlled drinker. And often this is a great goal to work to, and it's a realistic goal. But sometimes I'd be thinking, you really, because of the health consequences and life consequences, you probably need to stop. But what it does when you allow people to start with their own goal, they feel more motivated, they feel more hopeful. And a lot of people who start with harm reduction or a moderation goal, a lot of those people ultimately choose abstinence. And in my opinion, it sticks more because they came to it themselves. And they
100%.
got there in a way that feels good to them, that they felt like they had control over the process. So,
Yeah.
so I just think it's kind of case by case. But with alcohol, it's really getting people from, an amount of drinking that is going to get your liver and might cause arrhythmias and might cause other problems to a level where it's not going to be causing those problems.
And so you're a medical doctor, so you're monitoring these people so they don't have, if they're physically addicted to alcohol, you're
Mhm.
monitoring them so that they don't have seizures or the
Yeah,
DTs and
yeah.
all
So
that stuff.
yeah, so when we have an initial visit, so the first call is with one of our enrollment specialists, and then an appointment is made as soon as possible with either physician or nurse practitioner, as well as a coaching supervisor. But the first medical visit is generally done 3 days or less, and sometimes even the same day. And so, of course, on the initial visit, we're gathering history and getting to know a person, but of course, we're assessing for risk of withdrawal.
Okay.
And we do a measure called a CWA, which is probably more commonly seen in ER hospital settings. We've adapted it for telemedicine, and it's essentially a formal way of measuring alcohol withdrawal in the moment. You know, we get a history if someone's had a history of seizures or history of true delirium tremens, that puts them at higher risk. And it's very straightforward. Risk for withdrawal is how much do you drink? How many days in a row have you been drinking? And when was your last drink? So obviously, the more alcohol, the more days in a row. And then, you know, people can start withdrawing even 4 to 6 hours after their last drink. So we assess that. And there are situations where we recommend people go to the ER because we
Oh,
feel like
wow.
the risk of a medically complicated withdrawal is high enough that we feel like we can't manage it through telehealth. But there's a big group of patients in the middle who were able to manage withdrawal with gabapentin, which is not a benzodiazepine.
It is
Uh,
not. Gabapentin is not a benzo.
Gabapentin is not a benzodiazepine. It's not addictive. It's a very controversial medication. We could probably talk about gabapentin for the whole show, but
Wow.
I prefer not to. In the treatment of alcohol, it's extremely useful. In the population we work with, it's extremely rare for people to abuse it or divert it.
Yeah.
So you don't develop tolerance to it, so people don't have to take more and more and more. If you stop it abruptly, you don't have withdrawal seizures like you might have with benzodiazepines. So it's an alternative to benzodiazepines for managing alcohol withdrawal, which we think,
It's temporary.
yeah, it's really just to get through the withdrawal phase.
Okay, just for
Yeah.
withdrawal. Okay.
Well, no, I'll take that back. I mean, that use of gabapentin is to treat alcohol withdrawal. However, gabapentin also plays a role in long-term recovery as well. And in fact, research shows that doses of gabapentin between 1,200 milligrams and 1,800 milligrams a day can help people reduce heavy drinking days, have fewer days of heavy drinking.
Mhm.
And essentially, gabapentin can assist in recovery from alcohol use disorder by helping with sleep. And in fact, a lot of people who sleep poorly with alcohol is because they're starting to withdraw at 3 a.m. So if
Right.
you
Yeah.
drink a lot in the evening, you know, you wake up anxious, can't go back to sleep, you may be a little bit sweaty, you may be a little bit shaky. A lot of people will turn to a drink at that time to go back to sleep, but you can substitute gabapentin. So you can take gabapentin at bedtime to prevent that, and then you can even take it in the middle of the night. And then gabapentin helps with anxiety. For people who drink to self-medicate anxiety, it's a very versatile medication. But on the front end, we would use it for alcohol withdrawal as an alternative to a benzodiazepine. And then it's not safe to detox somebody from home. And I use the word detox very strictly, in that someone who wants to go to zero immediately.
Okay.
Because if you're drinking honestly 6 or more, 5 or more drinks a day regularly and go to zero, you're placing yourself at a great deal of risk. And so we don't do that detox. Having said that, we do help people reduce by prescribing gabapentin.
Okay.
And you're still going to be reducing by, 10% every few days. It's not, we're not
It's a slow taper.
slow taper. And so for people who are motivated with alcohol, they realize it's going to take a while to get to their goal. I think the hard part is, let's face it, all of us, human nature, when we're looking for help, we want relief now. We want to get going now. And as your
Mhm.
listeners know, or really should know, is that I've seen so many patients who are drinking 10 drinks a day. They get an ultimatum from their partner.
Right.
They're going to lose their job. You got to do something. Well, I mean, I think at that point, if you're drinking that much, going straight to a physical detox, and straight to
Mhm.
a residential program makes a lot of sense.
Yeah.
And so, but what people do is instead they just stop, and
Right.
then they have a seizure, and then they end up in the hospital, and then they may end up in residential treatment. So it's sort of like they got there the hard way. Or you could be
Right.
drinking 10 drinks a day and contact, RIA, for example, and we'll kind of help assist you in reducing your alcohol use over time, so you don't have a seizure, so you don't have DTs. And that, in my opinion, sort of that slow reduction, when done with the use of a breathalyzer, with the use of coaching, with use of medication, which are the three elements that Ria Health uses. When you do all those things, that people are successful in reducing their drinking on average, by 50% in the first month or two. So
Right.
anyway,
Yeah.
so it's the worst thing to do is just, and we all get panicked. We're humans, right? We want to be better right away. We don't want to lose our relationships. We don't want to lose our jobs. And so we don't always make the best decisions when we're under the gun like that. But I've
Yeah.
talked to so many people who just stopped, and then it was, pretty scary for them.
The interesting thing about making a decision when you're in crisis like that is that you're making an emotion-based decision, and emotions come and go with
Mhm.
sleep, with food, with an
Right.
hour, with a time, even a short amount of time passing, like an
Mhm.
hour. Sometimes like I'm upset about something or dysregulated, and an hour later I feel better. Right. So if I'm
Mhm.
making a decision from that
Right.
critical emotional space and then I change 2 hours later, I'm not going to be able to maintain or uphold that commitment I made when I was in crisis.
Right. And
Yeah.
that's why, right. That's why it's such great and common advice of like, stop, take a deep breath, clear your head. Don't,
Regulated. Yeah.
even to wait a few minutes then to calm down enough to make a decision. That's why that's always such
Yeah.
good advice, is shifting your
Yeah.
frame.
Yeah, I feel like so much of recovery is about emotion management, right? Learning
Oh
to
yeah,
regulate when you've been triggered. But and so there was a lot you said that I wanted to respond to. If we can
sure,
circle back to gabapentin for just a second.
sure.
We highlighted how it can be used in a positive way, like the
Mhm.
appropriate use of gabapentin. And maybe there's some cons we should be aware of. Like, what are the major criticisms of gabapentin that we should just take into consideration?
So, from time to time, like all medications, there are side effects. And
Okay.
the most common side effect with gabapentin is basically drowsiness and fatigue is by far the most common. So sometimes, let's say you have somebody who does drink because of anxiety, they may try a dose that's too strong. They might take it at 9 in the morning before going to work. And if the dose is a little bit too high, then they might have trouble like going to work and functioning. And so
You're not supposed to drive on gabapentin, are you? If it's a low enough dose, maybe?
it's a good question. I mean, I think you've got to have a sense of how it affects you. And so for some people, they have absolutely no side effects. And in that
Oh,
case,
okay.
it's not like,
It's not
Valiant,
like alcohol or
even weed. I mean,
yeah.
and certainly alcohol. So if you're having drowsiness from any medication, you should think about not driving.
Okay.
So, and then sometimes gabapentin, when it's prescribed at bedtime, if the dose is a little bit too high, you may feel drowsy the next morning. So basically, it's just if it's a little too strong, you can have drowsiness and fatigue. Now, having said that, I would say it happens, but it's very unusual. I would say in the range of 1 in 100 or 200, where people get really loopy on it and confused. And if that's
Mhm.
the case at any dose, just stop it, obviously. But that's true
Right.
also. Honestly, that's true with SSRIs. Probably 1 in 100 people take Lexapro, Prozac, Zoloft. You can also get very loopy, agitated, irritable. If you have any kind of adverse reaction from any new medication like that,
Hmm.
just stop it. And it's not the right choice for you.
Yeah.
And then the reason gabapentin is controversial right now is that it has been found in the autopsies of people who've overdosed on opioids, fentanyl and heroin,
Mhm.
and
Oh,
it's found comorbidly a lot. Now, the reality is the gabapentin didn't cause the death, most likely. Gabapentin is really safe. I mean, the doses go up to 3,000, 4,000 milligrams a day with no toxicity other than you get
thousands
tired.
of milligrams?
Yeah, so the usual dosing is kind of 600, 900, 1,200 milligrams a day is kind of, I would say, moderate dosing. High
Okay.
dosing is 3,000 milligrams. So it's a really safe medication by itself.
Okay.
But what happened is that we found it in all these overdoses. And I think that the thought is that people who abuse opioids also are, quote, abusing gabapentin. Now,
Mm.
if you think about it a little bit longer, so if I'm a pain management doctor and I have you on chronic oxycodone and you're taking more and more and more, a reasonable goal would be, can I somehow get them to take less oxycodone? Obviously over time, I mean, another form of harm reduction. So gabapentin is used in managing chronic pain also. So a lot of people who have gabapentin in their systems who've overdosed, it's been prescribed to try to reduce the amount of opioids they're taking. And so if it's found in in the toxicology reports of these autopsies, it's hard to say that there's a causal link. But the bottom line is,
Right.
7 states in the US have made gabapentin a controlled substance. And these are all 7 states have a very high overdose rate of heroin and fentanyl. So it's controlled substance. It's controlled substance level 5, which is the very lowest level of control. You know, Adderall and pain medicines, et cetera, are level 2. So it's sort of like and the bottom line is it's very political at this point.
Okay.
You know,
Okay.
that states with high overdose rates are under pressure to do something. And in fact, there's a petition of the DEA, of the FDA right now to schedule gabapentin on the federal level. So, I mean,
Okay.
I've just had a lot of success with it, and I prescribed it in a non-substance using population. Before I came to Rhea Health, I was a psychiatrist in primary care for almost 5 years. I prescribed gabapentin for sleep. I like, Ambien is kind of crap. I prescribed it for anxiety. Xanax is terrible, really
Oh,
bad
yeah.
choice. So it's sort
Yeah.
of like gabapentin can do a lot of different things with a lot less downside. So I guess I wasn't kidding when I say it could take the whole show to talk
Yeah,
about.
no. I have a question about Xanax because I recently did an interview with somebody who was on an obscene amount of benzos. And what I didn't know is that it's not, is it let me see if I can spit this question out. It's too much apparently I had too much coffee today. Xanax, is that supposed to be short-term situational, not long-term? Is that true?
Yeah, that is true. And Xanax or alprazolam is addictive because it's really potent. First of all, because it's active at 0.5 milligrams. It has a very rapid onset, and you clear it really quickly. You
Right.
add those 3 things: potency, rapid onset, and rapid clearing. That equals addictive substance for any substance, essentially.
Okay.
So having said that, the reason it's great to take as needed for a panic attack is that rapid onset and potency.
Oh, okay.
In other words, so people who take it no more than once or twice a week for a panic attack, for example, that's appropriate and safe. What's not appropriate and safe is when people are placed on it as a scheduled medication. So for anxiety, if someone's prescribing, 0.25 or 0.5 milligrams to take 3 or 4 times a day, that's essentially, in my book, is malpractice.
Is how much in a day?
Well, those are low doses. That would be, those would be 2 milligrams a day. But I know people are on a
Oof.
lot higher, and I know people who
Yeah.
use Xanax, are abusing 6, 8, 10 milligrams a day. I mean, definitely know patients who are using 8 to 10 milligrams a day of Xanax. That's
Yeah.
total
But
abuse.
yeah, the gal I was
So
talking to was she was prescribed 6 milligrams of Ativan, and she was on it like for months and months and months,
yeah,
if not years.
Ativan is better than Xanax in that it's a little bit longer acting, a little more manageable. Xanax is difficult to manage. And then
Yeah.
if you're going to prescribe a benzodiazepine, for anxiety, you want to go with longer acting benzodiazepines. But having said that, there's so many other alternatives to treat anxiety than benzodiazepines.
Yeah, and I think the thing that concerns me, so I'm sort of playing with this term of medically induced addiction, where doctors are not asking what family history is, like is there a history of addiction, things like that, and then they're prescribing large amounts of pain meds, benzos or whatever.
Right.
and people are becoming addicted through their
Yeah.
doctor's prescriptions. And it just seems like there is such a lack of protocol to protect people.
Yeah.
Like we really need to be our own advocates and educate ourselves on the
Yeah.
medications that we're being prescribed, because
Yeah.
then we end up talking to doctors like you who are addiction specialists and have to do like the taper protocols that we're
Right.
talking about in these harm
Yeah.
reduction
I would,
protocols.
the thing with doctors and prescribing is that, to me, there's a problem on either end of the spectrum of being too loose with prescriptions. It's kind of what
Yeah.
you're talking about, and, giving large amounts and not taking a substance use history, et cetera. I think it's a problem on the other end of the spectrum, where doctors have been put under a tremendous amount of pressure to not prescribe opioids for pain conditions.
Right.
Essentially, I think on that end of the spectrum, that some doctors are downright miserly and medical legally risk
There needs
of
to be a balance.
insensitive. And they're, to me, either extreme is a problem. I think
I
the hard
agree.
part is operating in the middle and being consistent. And so when the federal
Mhm.
government says you've got to reduce your opioid prescribing, it's kind of a safe way to go of like, okay, well, then I'm not really going to prescribe to anybody except under only the conditions that the federal government says I should.
Mhm.
And then that's kind of a coward's way out. And then the other people who are oblivious and prescribing very freely, I mean, those are people who are now getting in trouble and, losing their licenses and things like that. So,
Right.
but it's, the general term for doctors causing harm in medicine is called being iatrogenic, iatrogenic. So that's in any setting where you made a decision or did something that was harmful to the patient ultimately. That's a
Iatrogenic.
25-cent word for your listeners, iatrogenic.
I might have to stay with my medically induced addiction.
No, I think that's very, but absolutely that's the case.
Okay.
And that's why I don't like Xanax, and I can't tell you how many patients come to Ria Health on Xanax. Now, most of them are not addicted to it. Most of them, have a pretty small amount of a prescription. They're taking it for anxiety, but I mean, I avoid it. I don't think I've ever started it in my 30 years of practice,
Okay.
but I've inherited it thousands of times, and then you have to
Inherited it.
manage it.
And
Yeah,
so if someone comes in and they're on the Xanax, and are you is your I mean, I guess there are a lot of variables, but overall, would your goal to be to taper? Is that part of harm reduction? Is you tapering?
well, it depends on how they're taking it, and it depends on whether they're coming to me as that part of their goal for their treatment program. I mean, I think
Mhm.
my work with Ria Health, we really focus on alcohol, but in
Mhm.
general,
Okay.
um, the other principle is only making one change at a time when you do
Mm,
anything with medication. And so as long as they're not, really abusing something, I mean, I'll probably
mhm.
just keep it going for now and
Okay.
focus on other things. I mean, I think one of the ways to go at it as well is kind of indirectly. And can you address whatever it is they're taking the Xanax for? So let's say they're taking it for anxiety. Let's say you find out their anxiety is driven by drinking, in that they have a lot of withdrawal. So they have panic attacks because they're in withdrawal. So, for example, if you can work from the other direction of helping them reduce their drinking, then indirectly, then you can address the Xanax later.
Well,
So,
that's so interesting, because that is sort of like, what we're talking about are like alternatives to regular 12-step. And
mhm,
what 12-step does is go to root cause issue, but they sort of,
mm,
the 12-step community, it's like abstinence first and then
right.
work
Yeah.
on all the stuff. And I clarify this for me. It's my understanding that of neuroplasticity is that neuroplasticity happens when you sleep, meaning, your connections are either growing or they're
Yeah.
pruning during sleep. And the alcohol disrupts sleep. I've heard of a
Mhm,
variety of reasons why people, the 3 a.m. thing, that's a very
right.
common. People wake up at 3 a.m.,
Yeah.
especially after a night of drinking. And, it's like if you're in a program where you're trying to learn and then you drink, then the neuroplasticity that would happen at night is disrupted and you're not actually learning. And so it's like, bailing water out of a boat with a hole in it.
Mhm,
Right. So I think
right.
that's sort of why, if you're not so physically addicted that you're going to have withdrawals, then the best course of action would to be practicing abstinence so that you can deal with root cause underlying issues, like
Right.
what is causing the anxiety, what is causing the trauma, how do we resolve the trauma so you don't feel the compulsion to drink.
Right.
Am I thinking about that correctly?
Yeah, I would say that's all true what you said. And I think, what I'm thinking as you're saying that is that a lot of people come in, at least that I see coming into the program, and a lot of them say, I'm going to have to stop, and I'm okay with that, but I would love in the long run to be able to have a glass of champagne at my daughter's wedding, for example. Now,
The fantasy of every
I know,
true
I know,
true
but you can't live
alcoholic.
without it ultimately. But my point is a lot of people get the abstinence who weren't planning abstinence in their recovery. I mean, I have a lot of people I see follow up. Let's say I have a follow up, a month, and I'll get on the phone and we do breathalyzers. So people
Mhm.
have a breathalyzer that they blow into, and that via Bluetooth connection, it goes to the app. So there's a Ria Health app on your smartphone.
Mhm.
Blow into the breathalyzer, the number shows up on the app, and then not only can the patient see it, but then also we can see it on our end. So I'm seeing patients later today, and when I'm preparing to see them, one of the things I'm looking at is their breathalyzer graph. So
So is that
I'll
just a function of accountability?
Yes, yeah, and that's so we've been doing this from the beginning. Ria Health's been around for 7 years or so, and this was part of the program from the very beginning. Part of it is to have quantifiable data so we
Data,
can
yeah.
track our outcomes. But clinically, the conversation I have with people is they like the accountability. And we ask them to blow first thing in the morning and then blow at night, before they go to bed. We tell them wait at least 10 minutes from your last drink, because otherwise you're going to get
Crazy.
astronomical
Yeah.
levels.
Yeah.
But a lot of patients over time will track that higher number, and a lot of people they can't believe it. They're blowing 0.2, which is almost triple the legal limit, right?
Wow.
0.15 or whatever, double the legal limit. So they come in, and then 3 months later they're blowing 0.02, 0.04. Again, it's not complete technically abstinence, but someone who is drinking one or two drinks, literally max two drinks. And people set those goals. My goal is to have no more than two drinks, and eventually
Yeah.
no more than twice a week. And then people can do that. But I guess my point is, yeah. So for accountability, people like the numbers. We have a lot of
Yeah.
quantitative people who like to follow the numbers. Other
Yeah.
people that don't want to do it or won't do it. But
Yeah.
I guess my point was is that I'm seeing this patient, and in my last note, I'm reading the note going, I haven't decided what to do in terms of abstinence. And then they come in and they've have 3 weeks of zeros. And I go, oh, it looks like you haven't been drinking at all. And they say, yeah, no, I stopped, and I feel so much better. So I think part of it's
Yeah.
case by case. And
Case
I
by
think
case.
a lot of it is the respect of, we trust you to make good decisions. We're here
Hmm.
to help guide you and consult with you, and we're going to tell us what we think you should do. But at
Hmm.
the end of the day, it's up to you and your decision. I love AA. I've had so many patients who their lives have been saved with AA. I have nothing against AA. It's not for everyone. And
Yeah.
I think, some people don't like to submit to a higher power, that they see it more of a dominance and submission dynamic. They don't want to be told what to do. And some people have to learn the hard way, right? That as Bob Dylan said, you're going to have to serve somebody,
Yeah.
that on the other hand, some people, they find a different path, and they get to where they need to go
Yeah.
on a different path. So
Yeah. I want to speak for my AA people because you know, I'm writing a book called The 12-Step Exploration Guide. And one, it's about what are the common barriers to entry, and what is the context and perspective that will allow people to sort of move around those obstacles so they can
mhm.
complete. Like, my whole thing is the 12 steps are a worthy endeavor. I will die on that hill. Like, it's a great exercise to go through. But I want to address the idea of dominance and submission.
Mhm.
And it's sort of an interesting, on face value, it does seem like dominance and submission because you are having to surrender, but you're actually surrendering to reality. Like
Yeah.
those of,
Yeah.
you know what I mean? Like
Yep.
those of us who wanted to practice moderation. I practiced moderation for 2 years before I had to surrender to reality, which was I was not somebody who was going to be able to moderate.
Mhm.
It took me 2 years to come to that conclusion. And what I'm hearing from you, which I think is very exciting, is that you're fast tracking that process. That
Mhm.
to be able to have data and kind, compassionate, empathetic support,
Mhm.
and to trust that you're putting into people, oh, you know what's best for yourself, you're going to make good decisions. I didn't believe that that was true for me. I wonder if my experience would have been different if someone would have said, okay, let's, because nobody was going to tell me to moderate. Nobody was going to tell me to,
Right.
everyone was like, you need to stop. And I really
Right.
did. but
Well, no, and that's the thing, is that's the journey for a lot of people. And
yeah,
that's, I get to sort of witness it when I see patients and they're like,
yeah.
I wish I could do that, but I can't. So,
So to finish that thought though about the dominance and submission, once I accepted reality, right, see things as they are, once I was able to surrender to the idea that I am not one of those people who can moderate, then it was accessing a higher power that was in service of me.
right.
Higher power serves me.
Right.
And and I'm somebody that does embody service. Like I'm a
Mm.
service girl. Like they say if you want to build your self-esteem, do esteemable acts. So service was a
Mm.
big, and
Yeah.
because 12 step is peer support, I had a
Right.
ready-made
Yeah.
fellowship where everybody was on board with the language, everybody was on board with the mission and the tools. And I had an opportunity to access people who could help me, but also people I could help. So it was like a closed circuit system that
Mm.
was, 29 years later, it's so far so good.
Yeah. I guess time will tell. So,
And I'm not saying that if you do the steps that you will stay sober forever. I'm not
right.
saying that you have to attend 12-step meetings forever.
Right.
I'm not saying any of those things. And
Right.
I just know that there's people that are just going to be got their hackles up about this. But I have come to understand that there are like everybody's in a different place. And what you were saying about it just depends. It just depends on the person. It depends
Mhm.
on their, access to help and resources, like willingness, access to resources.
Right.
There's a bunch of variety of things, but
Yeah.
I just wanted to like for those who are like 12 step, fanatics, there is, the idea is that we're supposed to be open-minded, honest, and willing.
Right.
So open-minded to the fact that everybody has to come to their, like, I feel like that, the moderation thing, that question is so vital to answer. I had to answer that question for myself,
Right.
or I never would have gotten to the place of abstinence,
Right.
long-term abstinence. So I'm on board with it, with everything that you're saying.
Right. I'm, I think the way you're thinking about it makes a lot of sense. A couple thoughts. One is a lot of people who come to us have already kind of done some of what you've done. And they say, I'm here because I want to stay abstinent.
Stay
And I
abstinent.
want, I'm absent. I'm not drinking now. I want to continue not drinking. And sort of say they feel like the program that we offer for them seems to be a better fit than AA. On the other hand, I have a lot of patients. I'd say a third of the patients I see use AA also in addition to this program. And so part of it is it's like, it's not like you come to our program and we're going to encourage you to keep drinking. We're not, that is not it.
Can you imagine?
And the conversation is, boy, the safest route here is abstinence,
Yeah,
and a lot of people are struggling with that abstinence thing. And a
yeah,
lot of people then over time decide, and I think you make a good point, is that we can accelerate the process for a lot of people. But I will say
yeah,
a lot of people come to us having done that 2 years of moderate drinking, and they weren't able to flip the switch to the abstinence. So they
yeah,
come to us as a resource to help them with that. And so we're going to go with whatever your goal is. The other point I wanted to make, in heavy praise of the steps and the big book, is that they're really a blueprint for life. I mean, I
yeah,
can't tell you how many times I've talked to people who've talked about how they're applying the steps.
yeah.
And I'm like, God, this is for people with depression, for people just with unable to get along with other people. And I sort of feel like,
It's life skills. Yeah, for sure.
yeah, and so drinking makes us harder to get along with, but also I think people are also, because they don't get along very well with people, they turn to drink, right? And then you suddenly
Yeah.
make it worse. So to me, it's guidance on how do you approach things. And then you
Yeah.
combine that with something like, mindfulness and meditation and sort of coming at it
Mhm.
from a different angle. And I think part of it is, in great respect for those who are, AA has done great things for you. I just think to be open for the fact that AA can mix and match, take what
Yes.
you like and leave the rest. It's
Yeah.
okay.
Yeah.
You may
It's
have
okay.
somebody who goes to moderation management and they don't dig AA, but they might do both. And so part of it
Yeah.
is, to me, it's like, figure out whatever works.
Yeah.
And to me, that's not being wishy-washy. That's being effective.
Yeah, and the thing is that when we talked a little bit about it in our pre-chat was that people are on a spectrum, and
Mhm.
everybody is somewhere on that spectrum. Even if you're not, even if people are like, oh, classify as normie, like I don't have a drug addiction, alcohol, substance use, or whatever. Um, all of us have a little something, something. Like we eat a little too much sugar, or we shop a little too much, or
Yep.
online viewing, shall we call it?
That's a good for a PG
Oh,
rated show like yours. That's perfect.
yeah, we're not PG rated, but and
No,
I've
no,
had many people on here that openly talk about porn addiction, but that's what I'm
Mhm.
talking. That's what I'm not so subtly talking about.
Yeah,
So everyone's on the spectrum. We all have ways to cope with stress, and then so when we cross the line, wherever that line is for us,
Mhm.
and we need to get some help, like so everyone's on the spectrum is kind of my point. And so I think we need to stay open-minded that what works for me isn't going to
Mhm.
work for anyone else. I feel like the longer I've been sober, the less I know what's right for anybody else.
Yeah,
I mean, it's like we all have to have a degree of humility. We really
humility.
don't, yeah, we really don't know what's going on for someone else. That's something that only we can decide. So, those that are listening that are concerned about this idea of moderation, just know that people are somewhere, they land on this spectrum. And then as they are practicing different tools and they're growing and evolving. And so where they
Right.
are on that spectrum begins to slide.
Mhm.
I feel like we're always sliding on that spectrum. Either we're evolving or devolving somewhere along that
Right.
spectrum, depending on stressors or a variety.
Right. I think another aspect of AA sometimes is and again, I'm generalizing, their traditionally hesitation with medication, either
Yeah,
psychiatric medication. I did want to touch a little bit on
we need to
the
talk
use
about that.
of naltrexone in particular.
Yeah.
Talk about the Sinclair method, which I know is out there, and can be really successful for a lot of people.
Can you tell me what the Sinclair method is? I've heard of it and I'm not sure I know what that is.
Yeah, so the Sinclair method is, there was a Dr. Sinclair, it's going back decades now, in his own recovery, I believe, who made the observation that naltrexone helped him to not drink, and this was probably pretty early on. Naltrexone's been around for about 30 years. But the Sinclair method essentially is taking naltrexone when you drink. And so it helps to reduce craving. And essentially, the way naltrexone works is it blocks the opioid system. So
Mm,
we have our own internal opioid
right.
system. And
Yeah.
I think the sort of catch-all word I use are endorphins,
Right.
runner's high, and so it's part of the pleasure pathway is having an opioid response. So the naltrexone blocks that. And so people find alcohol to be less pleasurable. It's not animal
Mm,
use. You don't feel sick, but you just don't get as much out of it. So it's easier to stop at 2 than go to your normal 6 or 8. So for the Sinclair method, the idea is you take it before you go out drinking, that it will allow you to meet a moderation goal for that evening. And these, to me, the people who do best with the Sinclair method are what I would call episodic binge drinkers. So people who are Friday night, Saturday night party, they don't drink much, if at all, during the week, and then really hit it on Friday and Saturday night. And, if you think about it, blackouts, saying things that you didn't mean to, having bad things happen to you.
that was
Um,
me.
and then what I like to refer to as life-threatening hangovers, where
Wow.
I had a friend who was a nurse in recovery, and he said, I would wake up and the tip of my nose would be sweating. And so, just really terrible hangover. So
That's
essentially,
alcohol poisoning, right?
yeah,
Yeah.
yeah. I mean, essentially. So, so it can work really well. I don't buy into all the theory that they have about this concept of extinction, et cetera, but I know practically it works really well for a lot of people. So people come to us often and want to do the Sinclair method. If you're a daily drinker, and even if you're 3 or 4 times a week drinker, I really recommend daily naltrexone. I mean, if you follow the Sinclair method, you're drinking every day, you're going to take naltrexone every day anyway. But
Okay.
anybody who's drinking heavily, sort of having naltrexone to take it every day, have it build up in your system. And
Mhm.
then naltrexone can be super effective in helping people reduce. So for people who are actively drinking, whose goal may be abstinence, but since they're having 8 or 10 drinks a day, you can't do a rapid detox without going to
Seizures.
a medical facility, in my opinion.
Okay, got it.
But for people who are focused on reducing slowly, safely, effectively on their way to abstinence, or for people who just want to get down to being that person who might drink twice a week, but it's going to be 1 or 2 drinks, and people do
Okay.
this. If I'm going out with my husband to dinner, I want to be able to have a cocktail, or, I might want to have 1 or 2 glasses of wine. I mean, to me, that's very reasonable, moderate drinking. So
Yeah.
the naltrexone really helps people drink less. Now, the naltrexone is not the fix. The fix is the behavior change. The naltrexone
Right.
is sort of the conversation I have. Is a very useful tool. It's really helpful. Part of it is, you're probably feeling hopeless about controlling your drinking. The naltrexone helps you have some success, so you have more hope. When you have more hope, you have more
Mm,
motivation. When your
yeah.
motivation is better, then you're going to have the courage to make the behavior change. So that's the way that I explain it. Naltrexone is not a forever drug for most people,
Right.
not on it for forever. They sometimes transition to the Sinclair method in the long run, where if they do have a special occasion and they don't want to have 10 drinks, they might take it then, but that might, So, um, so the other medications also, none of them are meant to be long-term
Okay.
solutions. So I sort of, the way conversation I have is these are transitional. You might be on these for a number of months, but basically they're all to assist you in getting to whatever your goal is. So,
Um, Thank you for sharing that. I just have to tell you, I really appreciate your compassionate and empathetic approach to all this, because I think that's, if nothing else, people need an emotionally safe space to process what they
mhm,
really think and how they really feel. I think so much of recovery is performative. Like
mhm,
we're performing for our spouse, our friends, our employer, but in those quiet moments when we're alone and we know what the honest truth is, like we need to be able to say that to somebody. Right.
mhm,
So I see that you're providing that really safe space for people. So I really appreciate that. But you also touched on behavior change.
mhm,
And in my mind, there are subconscious beliefs and thoughts or experiences that have been suppressed. Association is a mechanism for us to, it's a survival skill, really,
right.
meant to save us from things that we can't process. And so once people, and I'm interested, I meant to ask you, I want to start, don't let me forget, I want to ask you about people come to re-up for long term, they want to, they're sober and they want to stay sober. So
Yeah.
don't let me forget to, maybe this ties here, but the idea of, behavior change in this way, in my mind, is often about resolving the compulsion that comes from underlying trauma, or
Mhm,
maybe those unhealthy subconscious beliefs like I'm not
yeah.
good enough, I'm not lovable, those really core wounds.
Mhm,
How do you see, maybe you do there, Ria, what are the processes of
mhm,
resolving,
mhm.
those primary core wounds that are causing the compulsion to
Right,
use?
right. That's a great question. The sort of, having the warm witness, someone to talk to, that aspect of the treatment also comes not just with the doctors and nurse practitioners, but also with our coaches.
Yeah.
So our coaches are certified addiction counselors, so that
Okay.
KDAC or KSAC state level of certification. Um, and the treatment that they provide, a lot of it is evidence-based, motivational interviewing, cognitive behavioral
Okay.
therapy. But at the end of the day, it's very pragmatic. And some of the coaches are in recovery also. But
Hmm.
basically, what I tell patients, it's like tips and strategies. and then someone to be a witness to your journey. You know what I mean? And
Yeah.
I think
Oh,
that's part
yeah.
of what you're referring to is people need non-judgmental compatriots, and hopefully they have that from friends and family. Sometimes you do, sometimes you don't. And so the coaches provide a lot of that. And so that's sort of the breathalyzer, the meds, and the coaching is the third leg. Now, having said that, we probably don't do the deeper root cause work ourselves. And I think our focus really is pretty pragmatic tips and strategies and support, definitely emotional support. We do have a lot of patients who have trauma histories. And in fact, I would say of people who have alcohol and addiction issues, a majority have significant trauma. And to get better, you need to address the trauma. And then let's face it, trauma results a lot of times in long-term anxiety, long-term depression. And so those also need to be treated. So we do refer people to psychotherapy to sort of unpack and get support for depression, anxiety, and trauma. Sometimes we communicate with the therapist, oftentimes we don't. We also provide, when appropriate, medication treatment for depression and anxiety. And so a lot of people, half of people who come to our program have depression, 70%
Ah,
anxiety. And so, it's chicken or the egg, right? Anxiety and alcohol, depression and alcohol. The depression makes it worse, but then alcohol makes the depression worse. And people drink for anxiety, and then guess what? They've got alcohol withdrawal and they have more anxiety. So essentially, part of our approach is also helping people address depression and anxiety. Part of that is, directing people to therapy, which people get outside of our program. But we, and then we sometimes prescribe antidepressants. I'd say a lot of folks come in already on antidepressants and already in treatment. A lot of
yeah.
people come in, they already have a therapist and a psychiatrist, but I totally agree with you. And, definitely from time to time, I'm sitting with the patient, they're doing the breathalyzer, they're taking the medication, they're coming to their coaching sessions, their heart is in it, but they're still not just able to reduce, they're kind of stuck. And so a lot of times I'll say, it sounds to me like we're looking at some of the root causes, and it's hard work. It can be expensive. It can be hard to find a really good therapist. But I mean, the next step for you is probably to find somebody and kind of dig in a little bit more on root causes. So I definitely see it clinically. I would say our program is pretty pragmatic and doesn't dig in as much, but we definitely will treat the sequelae of trauma and, anxiety and depression.
So the majority of the people that are coming to you are at the beginning phase where they're really, wrestling with their addictions. Excuse me. The people that are coming to, they're in crisis mode. And
A
so,
lot of times, yeah.
mostly crisis mode. Maybe some people that are just like, I just need a little help getting over this hump or clarity. So it's just interesting. It's such an important phase that, the pre-discovery phase, I guess sometimes people call it, where you're investigating and gathering information and resources to find out what would work for you. In terms of maybe this is, it's probably not outside your scope, but I'm fascinated with like the trauma therapies like EMDR or internal family systems, or I'm not even sure that's considered trauma therapy, the somatic practices. What kinds of therapies do you recommend for trauma?
Yeah, I mean, I think, you mentioned EMDR, and that's definitely eye movement desensitization. I forget what the other is.
Reprocessing.
And it's funny because when it first started as a technique, it was literally focused on eye movement. I call it a distraction technique to sort of open up your unconscious mind a little bit more. But there's lots of other ways to do that. But absolutely, that would be one. The other one is DBT, or dialectical behavioral therapy.
Okay.
Which is it's a bit like the 12 steps. Anyone could benefit from it, because it sort of helps people recognize their emotions and not overly react to their emotions. And as you said very early in this broadcast, that emotions are transient, and that when we acknowledge, accept, and let pass our emotions, then we're in a better position to make decisions. Totally true. So DBT, dialectical behavioral therapy, is perfect for someone who gets in a lot of trouble for being reactive.
Yeah,
I mean,
someone has a lot of
some people
triggers.
are like true bipolars who can't really stop themselves, but most of us, most of the time, if we can
Yeah.
acknowledge how pissed off you are, and before you open your mouth and stick your foot in it, you have enough space to stop yourself. And then you
Mhm.
go, oh my God, I just was hijacked by rage. And
Yeah.
this situation doesn't call for that level of rage. And I think I'll just take a deep breath and STFU, you know.
Yeah.
So so DBT, dialectical behavioral therapy,
Okay.
for sure. We also refer people, we have patients who have treatment resistant depression, and you know, we will discuss, and as I'm a psychiatrist, so I'll often have these conversations every once in a while with a coach will send me somebody going, this guy's really struggling with their depression. Can you meet with them? Not so much to treat their depression long term, but to give them to a consult. And I've definitely had patients I've referred
Mm.
to seek out ketamine therapy for treatment resistant depression,
Yes.
or
Yeah.
transcranial magnetic stimulation, TMS, is another
Oh
thing.
yeah.
Just
TMS.
really
Yeah.
to, I do think we really do our best to take into account, you know, biopsychosocial. I mean, the medical side, whatever the meds are and medical conditions, the psychological, psychiatric. I mean, it's not that we can treat all that ourselves, can treat all of those things ourselves, but we can certainly have a consult, have a discussion, and point people in the right direction. Because treatment resistant depression and drinking, it's like, you know, people, if you have depression and you can't get a handle on it, what's your motivation to stop drinking? Why should I stop drinking? Oh yeah,
Yeah.
I know it makes me more depressed. You know, I'm living it. You don't have to tell me. But it's kind of like, you know, you don't have the hope or motivation to bother. And right,
Yeah.
and
There's nothing else.
you treat depression effectively, and people are like, oh gosh, you know, I'm really working against myself here by continuing to drink. And then you have more hope, more motivation. And to me, it's a vicious circle going down. And I
Hmm.
say it's a virtuous circle coming up. It's vicious cycle,
Yeah.
virtuous cycle. When people start getting better in multiple realms, they get better.
I feel like we're all on this spiral. It's like
Spiraling.
we either go up or we go down. You
Yeah.
know,
And the
we
world's
very rarely standing still.
and the world's a freaking spiral as well, particularly.
Yeah.
I know my head is spiraling.
I know there really is so much information to consider. But I just like the idea of, first things first, ask for
Mhm.
help, get somebody else's perspective, maybe somebody else who isn't under the influence of drugs and alcohol, and people who know what they're talking about.
Yeah.
So listen, I could probably talk to you all day. I think we're going to do round two on your podcast at some point. talk about
Sure.
talk about some other things.
Yeah.
But so where can people find you? I'm sure people are going to pick up on the fact that you're very empathetic and you have some resources and
Yeah.
strategies and a
Yeah.
safe place. How do people contact you?
So the best way to contact, you know, RIA Health, and I'm a medical director with RIA Health, so I'm in a leadership position, but I do
Okay.
see patients. I mean, I don't have a full load of patients, but I definitely also see patients. But
Mhm.
the company is called RIA Health, RIA Health. .com, and just go to riahealth.com. A lot of information on the website. It's pretty straightforward in how to make, you know, get a free consultation, and just start with an enrollment specialist to find out more.
And it's
And
all telehealth?
it's all telehealth.
Beautiful.
We're
Anywhere.
nationwide.
Okay.
We're in all 50 states and DC. We accept a number of insurance plans. We're working on getting more insurance plans. So there's a chance that your insurance will cover part or all of the treatment.
Okay.
And then we also have a self-pay option that certainly compared to residential, or certainly compared to a traditional IOP, intensive outpatient program,
Hmm.
is affordable. And so, you know, we want to improve our access. So we're definitely working on getting more insurers on board. Um, and then essentially you'll talk to an enrollment specialist, and then if it seems like a go, they'll get you scheduled with a doctor or nurse practitioner, and then also get you scheduled with a master's level, like social worker, for example, or counselor, who are our coaching supervisors. And so you'll
Got it.
have an intake done on the medical side and then on the psychosocial side. then you'll often start on medication. You'll get started with coaching sessions. So the coaching supervisors try to match you with a good coach for you, temperament,
Mhm.
etc. And
Mhm.
so you'll get going on that pretty quickly. I mean, we try to get these things really rolling in a week or less. And like I
Yeah.
said, from time to time, it's same day or next day appointments.
Oh,
So
that's great. I
yeah,
could see this being really helpful for people that are like moms with, lots of kids, or, executives with crazy schedules, and
exactly.
they can't, or people who can't really take 30 or 90 days out of their life to go work on
Right.
their, I mean, I don't know anybody who can, but sometimes people have to do that. But
And we do, and I do the intakes, and I actually 20% of the people who come to us would meet residential level of care criteria. So we do the
okay.
ASAM level of care criteria. And so we, in theory, can be an alternative to residential. I think we're a great option for aftercare. So
Okay.
people who have gone to residential and need to get back to home responsibilities or work
Yeah.
responsibilities, it's convenient and private. We're able to fit around people's schedules.
Yeah.
And, is it the same amount of structure as going physically to an intensive outpatient program? It's not exactly, but it may be enough
Yeah.
to
Some people don't have that option.
transition out of. So aftercare.
Yeah. Yeah. That's great. Well, thank you so much for your time today. It was very enlightening. I feel like I learned a lot, and we want to give people as many options as they can to recover. So thank you for letting me, ask those questions about moderation and harm reduction that I wasn't really clear on. The differentiation between alcohol and drugs. I think that was probably one that I understood but didn't really
Yeah.
articulate. So super
Yeah.
helpful.
No, and
So,
I want to thank you for having me on the program. I really appreciate your kind of honest, open, interactive, sort of bringing in your experience
yeah.
in such a way that feels like adding, to the conversation and not like it's just all about me, right? We're in that
Yeah.
all about me.
No, nobody likes to
Tom,
lecture.
you're
I'm tired of talking about me. You talk about me for a little while.
exactly how am I doing? How are you doing? Anyway,
Yeah. Well,
how am I
yeah.
doing? It's really so it
Yeah.
was great. I really appreciate the opportunity and
Yes, of course.
and thank you. Yeah.
Thank you so much.